I think he has been continuously working in Vaticolo to uplift the cardiac services of the Eastern Province. For a long time, he was the only cardiologist for the whole of Eastern Province. Over to you, Dr. Arul.
Thank
We can't hear you well. Maybe if you switch off the video. Yes.
and go directly go to the presentation. I will go through from the start. One is our main aim is to acid-base blood gas report reading. So first thing we should be able to understand the report, which has acid-base problem and the blood gases, oxygen, carbon dioxide things, and we have to interpret the blood gas report and get maximum out of it, and we need to know what could be the possible errors which can occur, and we should be able to identify the venous report also. Starting with everything, I'll share one report which is you must be familiar if you are working in CCU or any ICU. Now, new machines give a very detailed report with a lot of parameters. Most of the things we don't see, but we should be able to see the main things like some are calculated and some are directly measured. You can see pH, carbon dioxide, oxygen, electrolytes, especially sodium, potassium, and chloride, and lactate. With the blood gas, we see bicarbonate, carbon dioxide, oxygen, partial pressure, and a lot of things. So you can see. Can you see my pointer?
Yes.
Right. You can see pH, carbon dioxide, partial pressure of oxygen, and the sodium, potassium, and chloride levels. Then you come to lactate, and these are optional. Not every machine gives. And in calculated things, you can see main thing we are concentrated on bicarbonate. And in oxygen, you may see alveolar arterial. I will come back to that. So those things, if you know, you can calculate. You can get more, additional information. So before that, what gas can tell you? It can tell you about the pH. pH, we are everybody familiar with pH. We use pH to detect whether there's an acidosis or alkalosis. And carbon dioxide partial pressure, which respiratory function will be reflected there. Bicarbonate levels will be there, that is metabolic function of the body is there, and oxygen level, partial pressure oxygen is our oxygenation status. And as AA gradient, what that means is partial pressure of oxygen in the alveolar and the arterial different. So that gives a exchange efficiency, blood gas exchange efficiency of the lung. So what we are going to see is only these 5 important topics. So everybody knows that basic, you must have seen blood gas report, but we will see how accurately and deeply we can go. So let's see the acid-base status. Acid-base status, you all know, just to give an introduction about pH. You all know what is pH is. pH is a measure of hydrogen ions. So it's a log one inverted hydrogen ion concentration log value of that. So why we use log value? Because to cover big range. Why it is important to maintain the pH in the blood? Because all our enzymes and proteins are very, very acid pH sensitive. So it can't work in acidosis, it can't work in alkalosis. So body has to maintain maximum possible, make an effort to maintain the normal pH. That's the whole scenario, all problem comes in IC. So whatever the disturbance comes, body try to make it normal, try to make it back to normal. If it is not, we should help the body to make it back to normal. So if it is acidosis, hydrogen ions generally more than 44 millimole per liter. If it is alkalosis, generally hydrogen ions less than 36 millimole per liter in the blood. So to do this, to maintain the pH in the body in a optimal level, we have buffers. Buffers means when you become excess hydrogen and excess alkali, there are buffers which can absorb this and maintain the normal pH. So what's the main buffer we are having in the body is bicarbonate, which is the main extracellular buffering system, right? And you know how it works, right? When carbon dioxide and water water will bring H2CO3, which become dissociated into bicarbonate and H plus ions, right? So other buffers are hemoglobin, phosphates, and bone also do some buffering activity of the hydrogen ion. So what is the bicarbonate level in the blood? Normal value is 22 to 26 millimole per liter. We can, for calculation and all, we consider as a 24. Carbon dioxide level 40, 35 to 45 you can maintain. So 40 is the normal level we'll take. Just to remember these things. So this is a basic picture of the how body is buffered. This bicarbonate system is there in the right hand side. Bicarbonate and hydrogen become HCO3, and through the lung it exhale carbon dioxide, so water it needs. So it remove excess hydrogen by combining with this buffer. At the same time, phosphate buffers and ammonia all can do buffering activity, especially to the kidneys. So if the pH is abnormal, generally we call it acidosis. If the pH is low, if the pH is high, we call it alkalosis. In acidosis, there are two things are there. One is metabolic acidosis, other one is respiratory acidosis. Metabolic means acidosis due to metabolic um, losing of bicarbonate ion from the body. Respiratory means generally carbon dioxide retention, like carbonic acid in the form of carbonic acid. So that is you call respiratory acidosis and metabolic acidosis. Alkalosis is opposite, increase addition of bicarbonate ions in the body, and respiratory alkalosis is carbon dioxide wash out, right? Decrease carbonic acid. So these are the main thing. So the main thing we see respiratory and metabolic. So this is the pH equation. You all know pH is so for the simpleness we can make it pH proportionate to bicarbonate and improper the bicarbonate, when the bicarbonate goes up, pH goes up, and the inverted proportionate to CO2. CO2, if the CO2 goes up, pH goes down. So that means if the carbon dioxide retain, pH will go down, and if the bicarbonate goes up, pH will go up. That means main thing determining the pH is one is bicarbonate and carbon dioxide. That is a summary. So now we need to know what is a pH. If it is normal, no, it normal it could be low or high. If it is high carbon or bicarbonate can occur. If it is low bicarbonate, we call it metabolic. High carbon dioxide, we call it respiratory. At the same time, if it is high, you call it alkalemia. Low carbon dioxide, we call it respiratory alkalosis. the high background we call it, this is going to be, without knowing that we can't work out the alert. So what is, just see what is happening in respiratory acidosis. You can see pH will go down, respiratory, due to carbon dioxide retention. Because hypoventilation, generally it is hypoventilation, where it will not change initially. So once the carbon dioxide goes up, pH will go down. So what are the causes? What will happen to patient? Patient, generally it is hypoventilation, rapid shallow respiration comes, blood pressure goes down, skin become pale, sometimes cyanotic. Patient will develop headache, hyperkalemia, and any hypokalemia, hyperkalemia associated arrhythmias. So patient feel numbness, dizzy, muscle twitching. So what are the causes? Generally, respiratory depression, right? Airway obstruction like bronchial asthma, COPD, and some other lung problem like what you call pneumonia, COPD, ARDS, pulmonary embolism. All other condition affects lung will increase the carbon dioxide. So patient will develop respiratory acidosis. So what will happen? You can see the nomogram, right? This is the nomogram where x-axis is pH and y-axis is bicarbonate, where you can see this is the ideal place where pH is 7.4. When the respiratory acidosis occurs, means bicarbonate, carbon dioxide goes up. You can see the carbon dioxide level and the color here. This greenish yellow is a normal value. That is, you can see 40. And when the carbon dioxide level goes up, that let's say it's the pink, it's 60. What will happen? Patient develop a acidosis where pH will come down. Then what will happen? Try, without, if you don't change the, if you don't treat the respiratory function, carbon dioxide level will might persist in the same level, but pH might approach to the normal. This is a normal pH. You can see 7.4. It will approach to normal level by increasing the bicarbonate. You can see x y-axis. It will approximate the normal pH. So that is the body's function. It will somehow it will increase. It will break. It will working towards normal pH. So by adding bicarbonate, retaining bicarbonate, this will happen towards the. The problem with the respiratory acidosis, because bicarbonate is retention occurs mainly by the kidney. So it is not very quick, not like breathing. So it will take some time. Right? Mainly respiratory acidosis compensation will take some time. Let's see what is respiratory alkalosis. It is opposite, right? pH goes up. It's mainly due to hyperventilation. So carbon dioxide wash out. But hyperventilation, we are seeing these patients might come with a hyperventilative syndrome, tachycardia, blood pressure, hypokalemia, numbness and tingling. Hyperreflexia can come. Even severe status, they can go into seizures, anxiety and irritability. Mainly hyperventilation, anxiety, fear, and mechanical ventilation. Sometimes in the CCU or ICU, where do we see low carbon dioxide is not with the anxiety, but because of the ventilation. So improper ventilation or purposeful hyperventilation washout in some condition, anesthetist will do. They have to do it. Sometimes if you don't set the rate properly, and if you set the volumes, ventilatory settings properly, carbon dioxide will wash out. So what will happen? Ultimately, patient will end up with a respiratory alkalosis. So what is happening in the nomogram? Where pH is normal, once the carbon dioxide goes down, you can see the blue line of carbon dioxide is 20 by washing out. pH become high, that is alkalosis. What will happen in time? It will come, it will become, it will approach the normal pH by excreting the bicarbonate, right? It will try to, you know, this respiratory problem will not compensate immediately because of kidney will take time to retain or excrete the bicarbonate. So the main problem we have to solve the respiratory issue to come out of this in real world. So what is happening in the metabolic acidosis? Where um, bicarbonate goes down, right? pH will go down because of the bicarbonate loss. Carbon dioxide will stay. What will happen to patient? They will become headache, decreased BP, hyperkalemia, muscle stitch, warm, flash, and nausea. All these symptoms can occur, and sometimes patient become loss of consciousness, and the patient will develop a hyperventilation because of the compensatory. We will say you must have seen patient with diabetic ketoacidosis and all way hyperventilation. Patient will increase rapid breathing. So main cause is diabetic ketoacidosis, severe diarrhea where they lost bicarbonate, renal failure, and shock, right? These are the condition where somebody can develop metabolic acidosis. This is the main problem in the chronic CCU, ICU patients we encounter, especially diabetic patients, shock and diabetic ketoacidosis, diarrhea, renal failure. These are the people in the medical ICU you might see. So what will happen in the nomogram, where pH is normal, but once the pH started falling down due to bicarbonate loss. How they'll approach? It will approach towards the normal pH by decreasing the carbon dioxide level. That means carbon dioxide will be washed out. So this respiration compensation for by metabolic acidosis is fairly quick because breathing it can do very quickly. So when compared to respiratory problem, metabolic problem, compensation comes very reasonably quicker. If you any questions, you can always stop and ask. So what is happening? Metabolic alkalosis is opposite anyway. We know it's a bicarbonate retention. pH goes up. These are the symptoms. What are the causes? So over antacid. Some people might have steak acids, gastritis. A lot of patient comes with gastritis. They will take too much of acid, antacids, and might become cause bicarbonate alkalosis. Sometimes NG sucking, NG we'll put the NG tube for the patient and suck out the secretion. Where basically we are sucking out the hydrogen ions or acids. So ultimately patient develop alkalosis. So here the nomogram you can see what will happen. Carbon dioxide will not change. Patient become alkalosis due to retention of bicarbonate. Here, how they will approach normal pH by hyperventilating. That means by moving the carbon dioxide level towards high. Sorry, it's opposite. Hypoventilating. So respiratory rate will go down and patient will retain carbon dioxide to compensate. So you can see this in respiratory abnormality. Generally, what will happen if the pH goes up, respiratory abnormality, that means alkalosis, carbon dioxide should due to hyperventilation, carbon dioxide will go down, so pH will go up. In metabolic abnormalities, opposite, because if pH goes up, carbon dioxide moves also high. Why? It has to, as I said, carbon dioxide, respiratory compensation is quick. In any situation, if you see high pH and high carbon dioxide, the problem is metabolic alkalosis. If you see low pH and low carbon dioxide, once again metabolic acidosis. If both pH and CO2 moves opposite direction, that means problem is respiratory. Whether it's alkalosis or acidosis, it is respiratory problem. So respiratory problem, if pH goes, if you see a blood gas report, pH high and carbon dioxide low, then it is a respiratory problem. If you see a blood gas abnormality, if pH is low and carbon dioxide also low, then it's a metabolic problem. or high or low, whatever it is. And that means pH and carbon dioxide move the same direction. In metabolic problem and respiratory problem, it moves opposite direction. Bicarbonate you can't take here because it compensation is slow, as I said. So metabolic acidosis, addition of acid will increase the. We are entering into a new topic. What is that? What is metabolic acidosis? It could be addition of H plus or loss of bicarbonate, right? Addition of hydrogen ion might increase the anion gap. You know what is anion? Sometimes, if you people don't drink acid, right? Hydrochloric acid. If you drink it, it'll happen. But of course, generally, hydrogen ion added to the body by the some organic acids. In diabetic ketosis, lactic acidosis, all. So these are called, we call it anion. So by addition of anion, the H plus added to the body, which cause acidosis. Or in other way, without anion, this additional anion acid, somebody can develop acidosis due to loss of bicarbonate, right? Like severe diarrhea or some other loss like renal loss. So like that, acidosis can occur in two conditions. So if we see somebody with acidosis, we need to find out whether this patient having an acidosis by losing bicarbonate ions or addition of some other acids, which is anion acids. So what is anion? We'll see what is. So anion gap we must have heard, right? General in the body is a neutral. Nobody can be charged, right? We can't walk around as a charged person. So body will try to maintain a neutral in a electrically neutral, right? Yeah. So what will an anion gap? Our extracellular positive ion is primarily sodium. So potassium also included, but it's very small. So we tend to neglect that. We'll consider 3 to 4 no. So in extracellular fluid, what are the anions are? Chloride and bicarbonate. So these are the main negative ions, and sodiums are positive ions. So between this, generally it should be equal in a normal person. If it is not equal, that means there's another unmeasured anion present. That generally in our body there's an unmeasured anion which is called anion gap, which is normal. Normally it is 12. It occurs due to all anion mainly from the albumin, right? Let's say albumin, somebody get 4, the anion gap is multiplied by 3 is 12. That is the normal value. Let's say if somebody have 1 albumin, then anion gap going to be 3. So it is albumin dependent. So in a normal person, the normal anion gap is 12 contributed by albumin, right? This is the problem. So if it is more than 12, that means it is body got some anion from somewhere. So we call it high anion gap causes. What are the causes? One is lactic acidosis, right? Diabetic ketoacidosis or renal failure. Renal failure where you get all sort of things coming into the blood. So non-anion gap where bicarbonate loss or as H plus loss. Basically bicarbonate loss, everything same. So H plus retention or basically and bicarbonate loss. Diarrhea where bicarbonate loss, and renal tubular acidosis you must have heard where we will lose bicarbonate by retaining the high H plus. So these are the non-anion gap where there's no additional acids, right? Organic acids. So we need to find if somebody got a acidosis, whether we need to know this patient got high anion gap acidosis or normal anion gap acidosis. How to find? So calculate the anion. If it is acidosis and normal anion gap, that patient got a normal anion gap acidosis. That's simple. So how can we explain how body will, well, some pictures I have put, how this non-anion gap metabolic acidosis occurs in the body. You can see positive ion is sodium. This is equal in amount. Negative ion is chloride, bicarbonate, and unmeasured anion. Right? This is a normal. What will happen in non-anion gap acidosis? Bicarbonate goes down, and in that level, but chloride will come and fill it. So in this situation, you will see unmeasured anion is same bicarbonate low and chloride also bit high. So you sometimes you call it a hyperchloremic acidosis, right? Chloride will be higher than usual level 103 or 4 is the normal. Then if it is 115, 20, then you have to suspect that non-anion gap acidosis is present. You can check the bicarbonate also. So what will happen? Anion gap metabolic acidosis, but where you can see unmeasured anion goes up, which remove the bicarb also. You must be knowing that if the acid change becomes added to the body, it will combine with bicarbonate and try to reduce the bicarbonate level also. That's the problem. So otherwise it's a combination of compensatory mechanism where bicarbonate goes down. So where it will become charge become normal, total charge, bicarbonate going to be low due to unmeasured anion is high. So once it compensated, you will be at this state. But is happening metabolic alkalosis, bicarbonate going to be added here. So unmeasured anion going to be same, chloride might go down. This is bicarbonate. So it is metabolic alkalosis. So yeah. So if anion gap acidosis is present, if only anion gap acidosis is present, let's say there's no other problem, only anion gap acidosis, then anion delta anion gap, you call it a delta anion gap. But normal anion is 12, you calculate some anion gap. The difference between normal and calculated anion gap is called delta. That means that much of additional acid is being added to that person, right? So the additional added acid will remove bicarb from the body while compensating. So what will happen? If you see add to the different with the anion gap, delta anion gap, that different to the bicarbonate level will give the original bicarbonate level of the body. So let's say bicarbonate 24, anion gap is additional delta anion gap, like 16 anion gap. Your patient's anion gap 16 and normal anion gap is 12. So delta anion gap is 4. So what will happen with bicarbonate? 24 become 20. When you measure the bicarbonate level in the patient body, the bicarbonate will be 20 because that additional 4 anion will remove 4 bicarbonate from the body to compensate. So if you want to calculate the original bicarbonate, you add this 4 to 20, 24 bicarbonate level will be the original bicarbonate level when the patient was normal or before anion gap acidosis develops. So this will help in later for us, right? So as I said, the anion gap is mainly contributed to albumin. That is albumin is 4, we multiply by 3, you call it 12. So that is a normal. So there's a mnemonic, if you want, you can memorize it. Right, this is the plum seeds, araldehyde, lactic acidosis, uremia, methanol, salicylic poisoning, ethanol, ethylene glycol, uh, and diabetic ketoacidosis, starvation, all will bring high anion gap, right? So if you have lactic acidosis, you can measure the lactate level. If it is uremia, you can check the renal function. Methanol, check osmolar gap. Salicylate poisoning, you have to measure it. Ethanol, you have to measure it. Ethylene glycol, osmotic gap. Diabetic ketosis, check the sugar. Starvation, you have to ask the patient. So it may be not, okay, it's fine, but sometimes it may not be that be, it may not be simple always, right? There could be a more than one abnormality can coexist, right? Especially in the ICU patient. There could be multiple acid-base problem in a one patient. Then we'll have big problem in identifying which and which the patient got. Otherwise, our treatment and the outcome of the patient going to be a problem. In metabolic acidosis, there could be non-NN-cap acidosis and NN-cap acidosis can coexist. In a particular person or patient, there could be NN-cap acidosis like liver. There could be non-gap acidosis. Like if a patient had a diarrhea, they will lose bicarbonate also in other way, not only due to gap acidosis, compensatory. They will lose by diarrhea. So in that patient, there could be both will present. We might think it due to compensation. When you measure the bicarb level in the diabetic ketoacidosis patient, the bicarb level is very low. Then you might think it's a compensatory mechanism that it has lost. But actually the patient has lost bicarbonate due to diarrhea also. How can we differentiate? That's the reason I said you have to calculate the delta and gap. At the same time, there could be respiratory and metabolic abnormalities coexist. So if the patient develop a pneumonia also, then there could be another respiratory abnormality with a metabolic problem. So all these problems can come together. So we have to dissect each and every problem separately and find out, okay, so blood gas is there, and from the blood gas we should be able to dissect the blood gas and find out, okay, what and what this patient got. So which one should treat at first, which one we shouldn't treat. Those things matters to make the patient survive. So if somebody with anion acidosis and non-anion acidosis, what will happen? They are, you can see bicarb also down, unmeasured anion also high. So where you can see the whole bicarb is, actually the bicarb level should come here, but it is low. So in this situation, how can we identify? This we will study by formulating an algorithm. We can simply find out all. In metabolic alkalosis and anion capacitors, what will happen? You can see bicarb goes up, unmeasured anion also goes, right? There's an acidosis and there's a metabolic alkalosis. Right? That's the problem. So patient pH may be closer to normal, but it is not the correct thing. Right? We might think, okay, pH is not much, but definitely we have to look at the anion gap and the bicarb level. See, it's a normal compensation or it's a problematic mixed problem, right? So what is the algorithm? It's very easy, just to remember this. That's it. First thing, you calculate the anion gap. If the anion gap is normal, then it's fine. It is not a non-anion gap acidosis. It is a, if it has an acidosis alkalosis, whatever it is. If it is anion gap is normal, then you can say, okay, anion gap acidosis is not present. Then you can leave it to go to the next level. If there's a anion gap, then you have to calculate the delta anion gap, which I said already. Which delta anion gap is the difference between the how much anion has added. That is the delta anion gap. We have to calculate. That means we have to calculate the anion gap and reduce 12 from there. That is the additional acid that's been added. Then you have to add that to present bicarbonate level to know what has happened to bicarbonate when the patient admitted. Means before developing anion gap acidosis, what could be the bicarbonate level? Because somebody would have had, sometimes some patient may have had alkalosis, but alkalosis by retaining too much of bicarbonate. Then by adding non-anion gap acidosis, bicarbonate come to normal. So if we add current bicarbonate level, the anion gap, delta anion gap, then you will get a original bicarbonate level. Then you will get to know if there's a high bicarbonate originally, patient must have had a alkalosis also before developing anion gap acidosis. So there's a two problems. Okay, if the bicarbonate level is lower than that, if it is not equal, that lower than that, there could be a inadequate compensation or there's additional acidosis which losing bicarbonate also possible. That will come later. So they'll come later by seeing the compensatory pathway. If there's a calculate the delta anion gap and correct the bicarbonate level, see whether patient got another abnormal, another metabolic derangement. Then determine the primary problem. So now we'll have too much of problems. We don't know what is the main problem. So to determine the primary problem, as I said earlier in the previous slides, you just have to look at the pH and carbon dioxide. If the pH moves, pH and carbon dioxide moves opposite side, then it's a respiratory problem. If the pH and carbon dioxide moves same side, then it's a metabolic problem. Why it is? If the carbon dioxide goes up, the pH should goes down. That is respiratory problem. The carbon dioxide goes down, reduced, it's a respiratory alkalosis. pH should go up. That's the reason. So if pH and carbon dioxide moves opposite direction, which is whether it is acidosis or alkalosis, it is respiratory problem. So next you see what is the primary problem. Check at the pH and carbon dioxide level. That's it. Then you find it's a primary problem is that. Then the compensation you have to check whether this primary problem is compensated or not. Or generally some in a straightforward condition you should be able to do it, but in a severely mixed problem we will have problem to identify whether compensation is adequate. Compensation means bring the pH normal. Sometimes you will get the normal pH by having a mixed problem. That is not the compensation, it's a mixed problem. So that also we need to consider. So let's say simple interactive case study. You can see it's a basic blood gas report we got in the undergraduate where they give pH level, carbon dioxide pH level acidosis 7.25, carbon dioxide 50. So it is carbon dioxide retention, bicarbonate normal, and oxygen also bit low, right? So what's the primary acid-base disorder here? pH down, carbon dioxide going up, opposite. It's a prime respiratory problem and respiratory acidosis. That's fine. Is the compensation adequate? It is not adequate. Why? pH is still low, right? What's your differential diagnosis? We know that we can see pneumonia or something, respiratory problem. We can say it. This is a simple problem, but when we interpretation is pH is low, is acidemia, carbon dioxide elevated, CO3 normal. It's a respiratory acidosis. So compensation incomplete because and PO2 is borderline hypoxemia suggest monitoring oxygen level. That is a previous case. So right, fine. But if we have a case like this, right? Let's say, shall we try this case? Get a paper and the pen and write it down and calculate. We will execute our algorithm, right? Our pH is 7.3, right? You can see without seeing below, just calculate what I am saying. Bicarbonate is 9, it is low, right? Carbon dioxide 22, it is once again low. Sodium available, chloride also available. So what our first step is to calculate anion gap, right? You know what is anion gap? It is here, sodium 140 minus bicarbonate and chloride. Anion gap is 54. It is very high. So what is the normal anion? 12. So 54 is very high anion gap. So there's an anion gap acidosis, there's no doubt. So then we have to see what is the original bicarbonate level. Bicarbonate is 9. Now probably it has compensatory decrease. We need to know whether it's a compensatory reduction of bicarbonate or some original bicarbonate problem also, metabolic problem also there. right? So what is delta anion gap? 42. When you increase, when you add this corrected bicarbonate, 42 plus 9, bicarbonate level is 51. That is normal level is 24. 51 was the original bicarbonate level. That is something wrong. So the patient must have had metabolic alkalosis to start up with, not only the anion gap acidosis. Patient had metabolic alkalosis. After that, adding anion acidosis and anion gap acids, anion gap acidosis, bicarbonate gone down very much. It falsely saying patient having low bicarbonate. No, not really. It is patient must have had a high bicarbonate level. So it is a primary problem. It is a metabolic alkalosis. That is the problem, right? So what is the primary problem? I said pH, check at the pH and CO2. Both are moving same direction. That means primary problem not due to respiratory carbon dioxide retention. So it is a metabolic. Primary problem is metabolic problem. Patient got a anion gap acidosis, started with metabolic alkalosis, and it is metabolic problem is the primary, right? So now we'll check out the compensation. How the patient, this patient can compensate. Generally, metabolic alkaloacidosis will hyperventilate. Metabolic alkalosis hypoventilate. As I said, it's very quick because respiration is quick. Respiratory problem compensates because it's renal, right? That's a compensation occurs, right? In respiratory, generally, the increment of 10 carbon dioxide will increase only one bicarbonate level, right? That is the compensation occurs in acute. So bicarbonate will take time. So that's the reason it will only increase one. So if there's a history of patient with the COPD, we should, if the bicarbonate level every 10 carbon dioxide retention, the bicarbonate level increased by compensation. That's a normal compensation. If it is bicarbonate is low, metabolic alkalosis present. If the bicarbonate is compensation less than 3, then you say it is a inadequate compensation by any other means, right? In chronic alkalosis, in respiratory acute alkalosis, every 10 carbon dioxide reduction, there will be 2 bicarbonate loss. Respiratory problem, every 10 carbon dioxide reduction, get you get 4 bicarbonate loss. I believe everything is clear so far. Okay, we'll do some examples, then you will get to know. If it is metabolic, where there's no acute and chronic, only acidosis and alkalosis, if the one loss of bicarbonate, carbon dioxide will reduce by 1. That's fine, right? If it is 2 increment of bicarbonate in metabolic, there will be 1 carbon dioxide increment. So that is a compensation occurs in metabolic. And respiratory is the opposite because unequal. It is unequal because kidney will take time. But in other way around, every bicarbonate loss, there will be 1 carbonate immediately. It will compensate generally. Right? This is a compensation. So if we know this chart, then we can, at the end of the calculation, we should be able to tell whether compensation is adequate or not. Of course, I believe you have to remember this. If you can write it down, also fine. You must be having the presentation. If you want to do the calculate, you need to know this, how the compensation is, right? So now we'll come to the same case, right? We have seen metabolic So how, let's see the compensation, right? See the bicarbonate loss. Bicarbonate has from 24 to it has 9, so it is loss. Bicarbonate loss is 15. So how carbon dioxide should go, right? 1 actually, it is 18. So almost equal. It's a metabolic respiratory compensation, almost adequate, right? However, this, of course, this is a mixed problem, so compensation cannot be tell very accurately. Any question? Okay, fine. So shall we solve this, please? Can you do this question, everybody, and anybody who can answer? Does this patient have anion gap acidosis? Yes or no? Can answer somebody? Can you hear?
Yes, I think they are answering through the chat.
Okay, okay, okay. Okay, never mind. You answer. I will tell the answer later. You just see whether it is yes or no. Second question, same question, right? Is the primary problem metabolic or respiratory? Check on the carbon dioxide and pH. The pH is low. We'll take it is low here. Check the carbon dioxide. Both are moving. Which direction? Okay, fine. Is there any additional respiratory problem? So then this is the problem for us. This one we have to calculate. Check the anion gap as delta anion gap. Check the bicarbonate level, corrected bicarbonate level. If it is high or low, and check the compensation. Okay. Now we will see the answer, how it goes. You want to see? Okay, put the question again. pH is 7.3, bicarbonate 16, carbon dioxide 24, sodium 134, chloride 108. But it's anion gap, it's 10, almost normal. So it is low, in fact. So a patient may have had a low albumin probably. So let's say it's 10, almost 12. It's normal anion gap. So there's no anion gap acidosis. The first question is no anion gap acidosis. So second is we have to see the delta anion gap. There's no anion gap acidosis, so there's no point of calculating the delta anion gap because there cannot be a bicarbonate loss any other means. So just leave the second step. What is the primary problem? pH coming down and carbon dioxide also coming down. So it is a metabolic problem. Acidosis. So metabolic acidosis is the answer. To compensation, if you know, do you know that metabolic acidosis, if it is acute, every bicarbonate loss, there should be a one carbon dioxide loss, right? See, but what is the carbon dioxide bicarbonate loss? Is 24 minus 16, that is 8 bicarbonate loss. What is the carbon dioxide loss? Is 40 minus 24, then 16 loss. So it can't be. The metabolic acidosis should be compensated by 8 carbon dioxide only in acute state. But it has been compensated. There's loss of carbon dioxide has come more than 8. So you can't overcompensate something. That cannot be happen. So you can't overcompensate. So what if that overcompensate means there could be respiratory additional respiratory alkalosis. That means patient has lost by carbon dioxide by some other means or hyperventilation or ventilating. Patient has lost carbon dioxide, which is more than the compensation. So there's additional respiratory problem is alkalosis present in this case. Got it? Oh, so in that stage, we can't talk about compensation because there's additional alkalosis. We don't know how much carbon dioxide retained due to alkalosis. It is not due to the compensation. It is some other problem. So since there's an additional respiratory alkalosis, diagnosis is metabolic acidosis and additional metabolic respiratory problem. Okay, yeah. So it is not a simple metabolic acidosis. It is there's a respiratory alkalosis also present. That means this all you must be wondering why one person how can somebody can have acidosis and alkalosis same time. Yes, they can have it, but the net effect is acidosis, but patient have had a respiratory alkalosis also, which also need to be treated. Unless what will happen if you treat a metabolic acidosis, patient respiratory alkalosis will become worse, right? So we'll correct the acidosis. We'll moving the patient towards alkalosis. But if we don't treat that respiratory problem, patient may end up in alkalosis and its complications. So once again, some another case, right? Sodium 143, potassium 5.6, chloride 106, bicarbonate 7.1, urea gradient, just leave it. And then they have given here actually 30. Of course, it is increased. Normal anion gap is 2. So carbon dioxide is 32. Gone down. So don't worry about it because patient probably the FiO2 patient. So it is calculate the anion gap. How can you calculate? Anion gap acidosis because anion gap is 33. They have given already. Anion gap is 30. Sorry, yeah. Delta anion gap 33 minus 12, that is corrected bicarbonate is 24. Patient might have had slightly towards metabolic alkalosis starting with. So that is the issue. Primary problem is metabolic because pH and carbon dioxide moving the same direction. You can see the pH, acidosis, carbon dioxide also low, both are moving same direction, which cannot happen in respiratory problem. So compensation in primary problem is metabolic acidosis. In metabolic acidosis, you know, one compensation should be 1 by 1. Here bicarbonate is carbon dioxide is lower than the bicarbonate, right? So you here opposite here you can see bicarbonate is low, carbon dioxide is high, that alkalosis. Here there could be an inadequate compensation occurs, or there could be additional respiratory acidosis. So anion gap acidosis with metabolic alkalosis where compensation not adequate, or there could be respiratory acidosis additional problem may be there. So that's the reason carbon dioxide was compensation was not adequate. So you can sometime carbon dioxide maybe retention may be there initial. So you have to see on the patient history to decide for this patient. Let's say then few words about treating metabolic acidosis, which is a common problem we encounter. Treat with alkali therapy is usually indicated to raise and maintain the plasma pH to greater than 7.2. If the patient pH comes down below 7.2 only, we should consider treating this patient. So otherwise what will happen if you don't know, if you don't calculate the initial this algorithm, sometimes patient may have starting from the metabolic alkalosis, we will give bicarbonate, it will worsen the problem. So if the pH is below 7.2, then and continue falling of bicarbonate level, that means we are not adding any acid or losing bicarbonate somewhere. This is especially true when carbon dioxide is close to the lower limit, right? When carbon dioxide compensation is very low, that means carbon dioxide washout is goes up to 15, then respiratory arrest can occur. Patient can't more than hyperventilate more than that. Then respiratory failure will occur. So in that situation, we may have to treat. The second situation, a well-compensated metabolic acidosis with impending respiratory failure. Yeah, that is the second. So if the continuous falling of bicarbonate and acid pH is level 7.2, then you consider treating with bicarb. Otherwise, patient in respiratory failure. In lactic acidosis and diabetic ketoacidosis, caution must be exercised because if you try to correct the acidosis with bicarbonate therapy, unless pH is closer to 7, so otherwise what will happen? The organic anion can regenerate bicarbonate when underlying soil is correct. If you start treating the diabetic ketoacidosis, the bicarbonate will regenerate. When you remove acid by treating the diabetic ketoacidosis, lactic acid, whatever it is, then bicarbonate will start to retain. Then if you correct the bicarbonate therapy in this situation, we will end up with the alkalosis. So there's a formula to calculate bicarbonate deficit if we want to correct to a person is uh, desired level of bicarbonate level into half of the body weight, right? If you how much you want to correct and how much measured, if it is 9 and if you want to correct per liter, right? If it is measured is let's say 9, if you want to correct not to the 24 but to 15, then 6. That's a desired level, right? Desired level is 15. So measured is 9, desired level is 16. There must 15 is 6 into half of the body weight. That means if a 60 kilogram person, 30 into 6, 180, right? That is the calculation if you really want. So now we will move away from the blood gas. I hope you all understood. Of course, it is a bit difficult in first step. Please go through again and read the presentation and understand, right? We'll have some idea about oxygenation also. We must be familiar with this oxygenation curve, right? Sigmoid curve. You can see how oxygen loading and unloading, right? This is how it happens. All depend on this, right? So normal oxygen pressure drops from the atmospheric level to intracellular level. You can just see it. Atmospheric oxygen is 106 mercury. You know that because 20%, 21% of oxygen in 760 meter mercury is atmospheric pressure. So partial pressure, atmospheric oxygen pressure is 160, right? So 10% 76, so 2 is around 160, 20%. Clear. right? Then alveolar capillary oxygen, when you breathe in, alveolar capillary also will have oxygen pressure. That is called, generally it is 105, right? That is the normal. Then arterial oxygen, we all know, that is oxygen we see in the blood gas, is 95. This gap is called 105 to 95 is a 10. That is a gap between the lung capillary and the arterial blood gas. So alveolar oxygen and the arterial gap. Okay, right. So arterial oxygen is the peripheral oxygen. This oxygen become 40 when it travel along the circulatory system, and peripheral intracellular oxygen is 25. In periphery, actually the peripheral cell need only 2 millimeter mercury of oxygen to functioning. To deliver 2 millimeter only, we have all this kind of uh, coming from 160 to 2. In the venous blood, we'll have 40 millimeter mercury oxygen. This is the main oxygen level. Sorry. Okay. What is happening in carbon dioxide? Normal carbon dioxide pressure changes little throughout the circulation because as atmospheric is 0.3, alveolar alveolar and arterial carbon dioxide is 40 because of the mixing and all. There's no much change between alveolar and arterial carbon dioxide, not unlike oxygen. So we consider carbon dioxide diffuse in the lung promptly. So there's no problem. So interstitial, intracellular, venous carbon dioxide 45, right? Increased carbon dioxide production is rapidly compensated by increased alveolar ventilation, right? That is what we see. The carbon dioxide will wash out very quickly. Elevated carbon dioxide pressure suggests inadequate alveolar ventilation. If the carbon dioxide goes up, that means there's a big problem in the lung. Right, doubling alveolar ventilation results partial pressure going to half. If you increase the heart, if you see somebody with a carbon dioxide partial pressure is around 60, if you increase the respiratory rate by double, then it'll become half, means 30, right? It'll that quickly it'll wash out. So decreasing the respiratory rate from 60 to 12 to 6, increase the carbon dioxide from 40 to 80. So if you want to increase the carbon dioxide in the blood, sometime you may need, right? Then you reduce the respiratory rate setting in the machine. So somebody will teach you in the ventilation, I suppose, in the acute cardiovascular. Yeah, somebody must be, I think. So they will tell you about it. So hypoxemia, the efficiency of gas exchange between alveoli and the arteries reflects the state of the oxygen exchange in the distal lung and the blood. That is the problem. So this is called alveolar and arterial oxygen gradient. We denote that with a capital A minus small a gradient. They say it's a report card of the lung, right? By calculating this alveolar oxygen and the arterial oxygen, you can have an idea of what's going on. If an abnormal alveolar gradient is this suggest due to hypoxemia with abnormal suggest lung is a possible cause, right? That's a diffusion pressure problem. If the normal gradient means it's a CNS or it's a lung, it's okay, but it is due to respiratory suppression of central nervous system, right? Those are the, if there's a respiratory failure due to muscle problem, nerve problem, you will get a normal alveolar arterial gradient. But if you have problem with the diffuse ARDS or something, you will get a high gradient where diffusion is affected. So by reading the blood gas, you should be able to tell where the problem in the lung. Then we can treat them. To do that, we need to know how to calculate alveolar oxygen pressure. It's simple, right? What is happening? fractional oxygen. It is no room air, it is 0.1, 0.2. You know, 21% of oxygen, 21% is oxygen in the air. You know, we call it as 0.21. If you multiply atmosphere pressure into 0.21, you will get the this is PB is the alveolar, atmospheric pressure. 47 is a water vapor pressure. So we had reduced the 47 due to water in the air. So we had to reduce it, and in that FiO2 you get a atmospheric oxygen. From there you reduce this calculation. Carbon dioxide, partial pressure of carbon dioxide, consider carbon dioxide diffuses rapidly, it's same, not affected. 1.25 part of carbon dioxide you reduce, then you get a alveolar oxygen pressure. If you know alveolar oxygen pressure, arterial oxygen pressure, we know because by doing a blood gas. So if you reduce that from there, then you will get a gradient. In that gradient, if it is more than 10, then it's a lung problem. If it is less than 10 or normal, then there's no lung problem. So where you should be able to know this FiO2 in room air is 0.21, that is 21 percentage. It's our normal oxygen percentage in the air. Where barometric pressure is 760, we know that it at sea level, but of course in high altitude it is changes, right? Where water vapor is 47, carbon dioxide measured arterial in the carbon dioxide is measured in the arterial blood gas. So we assume that carbon dioxide measured and the exhaled carbon dioxide is same. We assume that lung problem will not affect the carbon dioxide by calculating this. Right, gradient is PaO2, that alveolar oxygen minus partial pressure of oxygen. Where PaO2 is predicted alveolar oxygen pressure based on this equation. Partial pressure of oxygen PaO2, then gradient is right. The same thing I was talking about, right? So now we'll see. Simply, if we want to know alveolar gradient minus partial pressure is the gradient, A gradient. How to check the alveolar gradient? It's all depend on the carbon dioxide, what you see in the blood gas, because all other things we know. FiO2 in room air is we know, otherwise in blood gas, how FiO2 the blood gas we know, we must be knowing by ventilation. What is the FiO2 has been set in the ventilatory machine. So that has to be taken in further account if the patient not in room air. So general blood gas will denote, generally when you're doing blood gas, you have to enter in the blood gas machine. What is FiO2? So FiO2 minus barometric pressure. FiO2 fraction of barometric pressure minus water vapor pressure. From there, carbon dioxide 1.25 portion of the carbon dioxide partial pressure reduced, then FPaO2 will come. That means alveolar pressure. Then you can calculate. So we will do some sum. So in which condition alveolar arterial gradient increased, right? Right to left intrapulmonary shunt, especially pulmonary edema, congestive heart failure, ARDS, pneumonia, lobar pneumonia, especially where gradient goes up and collapse of the lung. In this situation, this gradient goes up. So if somebody get a gradient in normal people in ventilation, you should suspect something is happened. Or if patient got ARDS, or patient got a pulmonary edema, or pneumonia, patient developed pneumonia or collapse due to ventilatory problem. Or there could be a VQ mismatch, right? Because carbon dioxide reflecting might spread severe level. So in this situation, we should see whether carbon dioxide level has increased. That means it's a widespread lung problem, like COPD. In COPD patient, you will the carbon level is high. In that condition also, your gradient will be high because changes, of course, it changes. Or interstitial, severe interstitial lung disease, right? Also, you will have high alveolar and blood gas. So normal gradient, where do you get? Where hypoventilation, neuromuscular, as I said, and central nervous system, or in high altitude, where the FiO2 itself low, right? FiO2 itself low. So now we can update the algorithm to see the blood gas. What is calculate the anion gap? Then delta anion gap to see the original bicarbonate level. Then determine the primary problem. Through that, check on whether compensation is adequate according to our chart, right? Then check on alveolar and arterial oxygen level. If it is more than 20, normal, okay, we can give some alerts. Up to 20 seems. If it's 20, then we have serious lung pathology. So condition invalidating this condition invalidating or modifying the blood gas results, just to for the information. Delayed analysis, everybody knows that, right? So carbon dioxide might go up, pH also falls, and excessive heparin decrease the bicarbonate level and carbon dioxide. So air bubbles, all we know, air bubble can increase the oxygen, right? Because carbon dioxide will fall, because atmospheric carbon dioxide is very, so it dissolve in the air bubble, then it go into the air bubble, then carbon dioxide will be falsely low. And fever and hypothermia, of course, our sigmoid curve changes. Now, hyperventilation of breath holding, of course, patient immediately develop alkalos by hyperventilating. So, hot cells might be. So, pitfalls in interpretation, venous errors can occur. You can uh, get the vein, air bubble, or wrong side, or wrong patient, right? We just have a claim here. Check on the oxygen, but other thing we'll see. Anyway, check on this blood gas. This is the first case I have put on the first screen. You can see the FiO2, they have put 40, right here. Barometric pressure also they have mentioned here, right? So in that chart, you can see the sodium. We'll check the anion gap first. Sodium is 124, chloride is where's that? Yeah, 101.4, and bicarbonate 17.7, bicarbonate low. So we'll see the anion gap. So anion gap is normal. So there's no anion gap acidosis. So what's the problem now? Acidosis there, bicarb also there, low. Let's see what is the original problem. Carbon dioxide, pH, right? What is the carbon dioxide is going? You can see carbon dioxide is 58. pH is of course low, right? 7.7, almost 7, right? pH low, bicarbonate going up, then in opposite direction. So it must be a respiratory problem, right? So if there's a respiratory acidosis, bicarbonate should go down to compensate. Every 10 carbon dioxide loss, there should be 1 bicarbonate, because as I said, renal cannot compensate. That is a rule. So every 10, it should be 1. But here, it's 18 carbon dioxide has gone up, but bicarbonate also low. It is not increased. So what is that problem? Patient got additional metabolic acidosis. Patient has already lost bicarbonate by some other means, so there's no compensation at all. In fact, we have additional. So patient got respiratory acidosis and metabolic acidosis. That's the diagnosis in this case. Respiratory acidosis how it comes, pneumonia or anything, metabolic acidosis can come with shock and things. So in a CC patient or IG patient, so patient can go into shock and metabolic gas and things in this patient. At the same time, we'll see. Okay, now we know this. What's a respiratory problem now? Do we have a clue? Yes, we can do a blood gas analysis here. Alveolar and arterial blood gas different. See, check on it. We calculate FiO2. As I said, it's 40% here. So it's 0.4. Generally, normally 2.1. Sorry, 0.21. Here 0.4. This is a barometric pressure they have given. And water vapor, sorry, is 47. So carbon dioxide 58.1. 1.2 fifth of 58 is 7.2. So calculated gap is very high. Alveolar pressure 182 point. Now we see the gap 182 minus 172. So even though it is really 105, but it is very high. Why it is high? It is because of the FiO2 we are given. FiO2 is very high. That's the reason it has gone up. Right? When you calculate the gradient, it is normal. So it is not increased. So there's no lung problem. So some problem, now we can calculate, say, there's no lung pathology, it's per se. So why the respiratory acidosis has come? Somebody has hypoventilated this patient, this ICU. So metabolic acidosis. So it is a wrong management, of course. I don't know, just by checking on this record, somebody with a metabolic acidosis, if you leave the patient alone, they will hyperventilate and correct it. But we have intubated and hypo make respiratory acidosis also. This is a problem when you see, if you don't know the blood gas management in the ICU. So this is how this is problem. So your patient. That's all. I think 9:30 for 1.5 hours. Everybody alive, I suppose.
Thank you, Arunidhi, for that lecture, extensive lecture. Now, if anyone has any questions, please you may ask through the mic, or you can put it in the chat. Thank you, Arunidhi.